Speaker is Dr. Harsh, who would be speaking on the normal tension glaucoma and the correlation of the disc with the normal intraocular pressure, where we can suspect the patient as a glaucoma suspect or maybe a glaucoma patient with normal tension glaucoma. Dr. Harsh Kumar, he does not need any introduction. He is associated with Center for Sight for a couple of decades, and before that he was associate professor in RP Center. Dr. Harsh.
Thank you, Prateek, for having me here, and thank you, AIOS. So let's move on straight away. And okay, so what exactly is normal? So it is the opposite end now we are coming to. Prateek showed you normal disc, normal fields. Here it is just the opposite. The disc and the fields are glaucomatous classically. However, the angles are open. And when you do all the pressures, you do a diurnal variation, you realize all the pressures are less than 21. So just to put it how exactly it happens, this male came to us. One eye was having less vision since childhood, and the other eye was okay. Angles were open, and the disc that I just showed you, superior notch here, so symmetrical inferior field defect. The other eye looking like a tilted disc, and this was the amblyopic eye, and classic superior field defect over here. And all the pressures were normal. The cornea was a little on the thinner side. The color vision is normal because that happens in the tilted disc sometimes. And so a provisional diagnosis of normal tension glaucoma was made. We ruled out steroid intake, trauma, because all these things can create this kind of a picture at one point of time and then they go away. So any long use of steroid, any CVS abnormalities, stroke, massive blood loss, all these things were ruled out, and then we did tests including the MRI along the carotid Doppler, hemogram, ESR, BP check, 24 hours. These are all parts of the NTG examination. The patient was put on Travo and advised 3 months later for IOP check and repeat fields after 6 months. The patient promptly disappeared and came back 26 months later, but the entire examination was same. The fields were same, everything was stable, and very proudly I told all my students, "Dekho bhai, bilkul perfect. Our treatment was exactly right." And then the patient says, "Sir, I never used the medication after 3 months." So this is NTG for you. So were we right in starting the treatment, or the patient was right in stopping the treatment? So this is something which we really have to understand. How the hell does it matter? Why don't we just start treatment? Because you have to understand whether it is NTG or whether it is OEG or ACG, because NTG is a different kind of an entity, an unknown entity where there are too many vascular factors also. So you are going to do too many other investigations, and it is not easy. All said and done, people in our country are still not reached. Getting an MRI done means maybe 8,000-10,000 rupees. So all these extra investigations will be added up. You will be doing 24-hour BP recording. These are done only in big hospitals, and again a lot of expense over there. So let us be clear what exactly we are talking. So have you taken your pressures correctly? Are you sure they are not by NCT? You have done a good applanation tonometry. You have done a 24. This is one place where we say that even if you have to send a patient to somewhere else, you have to do 24-hour pressure recording, because at least every 4 hourly, because you may be missing a peak somewhere. And if you get a peak above 21, oh, that's fine. Then it turns into an OAG and not an NTG. So please, a diurnal variation is a must in these cases. Second thing, any bad disc or any retinal anomaly, I'll tell you, so many cases I get, there's a huge cryomark somewhere, it is corresponding to a field defect, and for 10 years the bloody glaucoma treatment is going on. Nobody has bothered to look and correlate what the hell is going on over there. So please check the disc. Okay, if the disc is bad, it is going to give you a bad field, but doesn't mean it is glaucoma. So be careful that you are not dealing with a myopic disc. And Vinay is I am going to really listen to that lecture, because I have still not understood how really it is different. It is such a complicated thing. And whether it's a coloboma, whether it's an optic pit, so many BRBOs get a beautiful arcuate defect and they are being treated for glaucoma for ages nobody has dilated. It could be ARMD, and yes, pituitary tumors can give rise to funny kind of fields and you will be so confused. Intermittent ACG, so we have a lecture on that too. That itself can create a damage and you feel that it may be the pressures at one point of time may not be high. So essentially it's a chronic low vascular perfusion, Raynaud's phenomena, migraine, and hypotension, over-treated systemic hypertension, and the main causes of normal tension glaucoma. You have to be careful about the family history. Females are more affected. Thin central corneas are usually there. Systemic hypertension, the people who are having systemic hypertension are the one which are over-treated and get hypotension. And that is one of the major reasons. Migraine, Raynaud's, these are all symptoms that yes, there is some kind of a vascular anomaly. The disc hemorrhages are larger in these cases and commoner. And very, very interesting fact is, I actually just read it yesterday. I also didn't know that why are the hemorrhages larger in normal tension glaucoma. So the fact is that in a high pressure glaucoma, the eye pressure is high, so if it bleeds a little bit, the rest of the high pressure actually stops further bleeding. But in this case, the pressure is low, so you get a larger disc hemorrhage, and that is why they are probably seen for a longer time, and that is why they are more seen in the normal tension glaucoma. The fields are more focal, deeper. They are more close to the central areas because the central areas and the macular infarcts, and it is a vascular phenomena, so the central areas are more involved. And as far as the NRR is concerned, the focal ischemic notching is more common in this. The risk of progression is not related to severity impinging on fixation. Strange. But unfortunately, you'll have to treat because it is already near fixation. You already talked about it, but you have to do a 24-hour BP recording because if any of the BPs are less than 70 millimeter diastolic, then you have to be very, very careful. You have to contact the cardiac person and tell him that please sir, thoda reduce your medications. We don't want this because there's no blood reaching in the eye if the pressures are as low as that in the diastolic this thing. Check for, we always get a Holter also done because so many times there are multiple arrhythmias going on over there, and if that is going on, that's a good vascular cause. That is, the blood at times is not reaching the optic nerve. Hyperviscosity, hyperlipidemia, and now even sleep apnea is being implicated over there. You need to rule out burnt out glaucoma. Very, very important. So many of the patients have had a one-time thing and then they are being treated for ages. Steroid-induced, Posner-Schwarzman, traumatic, sudden elevation, massive injury, major surgery. All these cases can give. Some people after CABG I've seen after bypass surgery are getting these kind of things and then they are stable for ages. The deterioration is not related to age, hypertension and diabetes or family history also, but it is related to migraine, disc hemorrhage and being a female. There are at least 3 genes associated, but frankly speaking, they are very, very rare even in those cases. So really, one wouldn't be able to do anything clinically with that. So as far as the NTG study was concerned, the interesting factor was that 80% were okay in the treated arm. 40% were okay in the untreated arm. Overall, 40% NTG is IOP sensitive. 40% was okay without treatment, and 20% will progress even if you treat. So we know that we are dealing with something which is much, much more difficult. So who's to be treated? Make sure that it is actually needed. So many a times you might just want to check with the progression and see whether we are really on the right path, because you will have to use medications. And if somebody tells you that you do a trab, sir, I want a lower pressure than 14, then you are scratching your head, yaar, ki mera trab, if I am able to do such a good trab that I'll get low pressures than that, you might end up with choroidals and shallow ACs all the time. So if the patient is threatening fixation fields, IOP is on the higher ranges, field is deteriorating, wider diurnal variation, nude optic disc hemorrhages, deep localized knot, young age, systemic hypotension, vasospasm, myopia you'll like to treat. Start by getting the pressures 30% low, PG analogs. You can use all medications, but definitely don't use beta blockers because they lower the pressures in the night for the BP. And TRAB is a definitely last resort. Very, very important is that reduced CSF pressure is coming into the picture. So if the CSF pressure is low then this, even a normal eye pressure is going to push the lamina cribrosa and damage it. And that is what happens in myopia, because this is very, very stretched. So even a normal lowering can cause the gradient is too high. So individualize each patient and check up exactly what is the financial situation. Are the fields far advanced? Is it progressing? Ability follow-up, and then accordingly decide whether it will be medication or whether it will be surgery or whether it will be follow-up. Thank you very much for your kind attention.
Thank you, Dr. Harsh, for a very lucid talk and very practically very